with average blood sugar in reverse is I just want to get that blood sugar as low as I can. I have made what I feel like are pretty strong strides towards changing that, but I'm not seeing drastic changes in the labs.
I guess that's why I've become a bit suspicious of the lab's ability to reflect reality. I wonder how much realistically you are preventing by dropping an A1c from 5.6 to 5 or 4.5. I don't know that I'm convinced that that change reflects real improvements in health span. Lowering it from 8.5 to 7 does. But I mean, even in diabetics, right? It's a U-shaped curve on mortality for A1c control. Below 7, mortality actually goes up if you're controlling it pharmacologically.
Okay, so um, if I want to kind of move earlier in the metabolic process of insulin resistance, so we've looked at my A1c, we've looked at my fasting glucose, we've looked at an insulin with the fasting glucose, and I feel like we haven't done enough work to figure out kind of where I am in the metabolic process of glucose intolerance. And I'm wondering if there's a better test to do. Meaning, could I do a 2 hour glucose load with insulin levels along the way?
You
Or,
could,
or are there
although
tests that you feel like are both validated and not only appropriate for the research facility to do to evaluate this?
so you certainly could do a glucose load. I think given today's technology, the way we used to do that's a bit out of date. I think we should be doing that with a CGM. Like get a Freestyle Libra 3, and then yeah, you can mix up 75 grams of glucose if you want, or whatever you want to do, and do that fasted. But you could do that on multiple days. In other words, that way, in that 14-day sensor, you could have three different glucose tolerance tests at different times of day or different whatever, and kind of see the range of your response to a standard load. I think that would have value, sort of the area under the curve. So I think the modern version of that would be to get a CGM and get multiple glucose tolerance tests, um, and kind of an area under the curve kind of thing in terms of your insulin response. I guess and of course there's the stuff I do, which is the exhaled gases ratio of fats to carbs, right? Um, but I guess the bigger question for me is what is the goal? Because I don't know how much reducing insulin resistance just for the sake of it is particularly a goal. What's the intention there?
I mean, I'm starting to kind of view, you know, glucose intolerance, insulin resistance as the genesis for other chronic diseases and, you know, as a potential reduction to health span. And so, in an attempt to increase health span, getting, the further, there's going to be some rise, right, in average blood sugar over life. Just like, quitting smoking, you're, if you're reducing, you're going to have a reduction in, pulmonary function over the course of your lifetime. And by quitting smoking, you give yourself a boost today. It's still going to continue to go
Sure.
down. So same thing with average blood sugar in reverse is I just want to get that blood sugar as low as I can because I know that over time it's just going to continue to go up. And yet I feel like I have made what I feel like are pretty strong strides towards changing that, but I'm not seeing drastic changes in the labs.
I guess that's why I've become a bit suspicious of the lab's ability to reflect reality. Like, I think that I talk about that in this video, in that video you watched actually briefly, is like, normals were defined on a bell curve of people that have theoretically no problems, right?
Right.
I wonder how much realistically you are preventing by dropping an A1c from 5.6 to 5 or 4.5. I don't know that I'm convinced that that change reflects real improvements in health span. I'm convinced that lowering it from 8.5 to 7 does. But I mean, even in diabetics, right? The it's a U-shaped curve on mortality for A1c control. Below 7, mortality actually goes up if you're controlling it pharmacologically. So
Right.
so I do think even in diabetics, you can probably do better than 7 non-pharmacologically, right? And also that was on the older generation of drugs, so I feel like that needs to be repeated with the new, like how much of that rise in mortality was hypoglycemic events that we weren't detecting. So
Right.
with the new range of drugs that don't have that, we should redo that. But the core point is from 5.5 to 5, I wonder how effective that is in improving health span compared to, and I'm just sharing with you my mental model, compared to setting a functional goal. I want to be able to run at this pace for 40 minutes. Like, if you could, now, will that have effects on insulin sensitivity? Absolutely. That'll increase your sensitivity. But I don't know that focusing on the A1c is the best way of measuring that compared to focusing on time and time spent at heart rate, right? That's a more functional goal where if you can run or jog rather, if you can jog for 40 minutes straight, I don't know. I feel like that target is more health span oriented and I think is going to have better
Well, somebody with
outcomes.
an A1C at 11 could potentially run for 40 minutes straight and, out eat their running and stay at an A1C of 11, though.
Correct. I guess I was saying in your context of already having made dietary
Yeah.
and strength changes. Um,
Okay.
I guess my point is I think the A1C is great for detecting disease. Below the disease threshold cutoff, I wonder about the value of using it to track.
Okay.
Like it's kind of like BNP that way, right? Like BNP's good as a yes no, are you in heart failure, right?
Yeah.
Or you, but it's not great for tracking heart failure.
So does that come back to the CGM? And basically, I just need to compare myself on the CGM a month from now versus today. And if on average I'm doing better, then that's all I need to worry about.
Sure, and I mean I guess I would question the data set. I've never seen a data set indicating worse health outcomes at 98 than 78, right? Like I think you may be below the threshold of harm. Like the harm may be a threshold effect. And so if you're below that threshold, you might, if you're spending effort, you might spend effort on other things that would have a better payoff, like improving VO2 max or increasing strength as you have been. I think those things are going to have better payoffs than reducing your A1c from 5.6 to 5. So, or your fasting glucose from 98 to 78. Does that make sense?
Yeah, I mean, but
I mean, those other things might happen. I mean, you might get the lab reductions. I don't know what the value is
well,
almost.
let's just assume that. So I am doing some zone 2 walking 2 to 3 times a week on top of the
Okay, great.
lifting. So let's just assume that I have no more time to give to exercise.
Sure.
But I can manipulate my diet. I'm going to spend the time on my diet that I'm going to spend. And I could eat terribly or I could eat better. In eating better, I would also, in what I would call better, I would expect to see a lower glucose load, which I would assume would end up in a lower fasting blood sugar, postprandial blood sugar, A1c.
Maybe. I guess yes, but I think the timeline on that, and this is total just back of the envelope stuff. I feel like the timeline on that is way longer, like 2 to 3 years. I think that unless you start doing, like, if you want to fast for 60 hours, like a 60-hour fast, tw- 3 times, you know, you'll increase your insulin sensitivity. That's
Yeah.
just a drastic way of like you flatlining your insulin level and then your body becoming more sensitive as a result. Um, Without that kind of drastic, I just feel like the timeline on it is long. I mean, I think you will, but I feel like you're doing all the right things. If you're eating healthy, I would focus on muscle gain and body composition and yeah, I don't. In terms of what are you tracking, right? I guess that's kind of the thing. Is like, is tracking A1c useful? It's useful to make sure it doesn't go over 6.5. It's useful to make sure it's not rising significantly. If we were having this conversation, you said, oh, it went from 5.6 to 6.2. Well, okay, now something is amiss, right?
Yeah.
Now we need to be thinking. But just the fact that it's hanging at 5.6 longer than we'd like, I don't know that I'm excited about that.
And below the threshold of, the subjective term of disease,
Mm-hmm.
you, you don't even feel like it's worth necessarily focusing on a more granular view of blood sugar.
Okay, so
For,
that gets
for the
into,
pur-
yeah.
for the purpose of like it's a proxy for how well you're doing whatever you're doing.
I think it can be useful information if interpreted with the following caution. I think that the optimum health outcome is probably achieved from the highest level of variability, not from the lowest area under the curve. So I would again, assuming you're non-diabetic, right? So assuming we haven't gotten sufficiently dysregulated that the system is operating differently. Um, I would say that having, you know, whatever. I'm making up these numbers again, but if 90% of your time is spent with a blood sugar less than 100, 5% of your time is spent with a blood sugar less than 80, and 5% of your time is spent with a blood sugar above 150. I think that is probably more optimum than just spending all of your time with a blood sugar less than 120.
Yeah. Okay.
Does that make sense?
I
Like
think
I
so.
think the variance matters, and so we don't have studies on this. That's an extrapolation from what I consider a biological principle, which is always shaky until it's proven. But that's sort of my operating principle is that you're going to get more mileage out of variance than you are out of. And the only way to do that study is to see who dies first. So I don't think that study will ever be done. But yeah, I think there's a lot of people doing CGM stuff that are just trying to lower it as low as possible, and I don't know that
Yeah.
that's because again, it's never been studied. Like it's like okay, if you fast for 60 hours 3 times, in 3 months or whatever, increase your insulin sensitivity, and then go back to eating normally. I doubt that has any long-term negative health outfit, right? But if you're constantly trying to keep your sugar as low as possible, as much as possible, and your A1c is 3, like I don't, you may be doing harm. Like I don't know that that's been studied in terms of its positive or negative effects. Like that may be its own form of stress on the system.
Well, but that's an extreme case. But I mean, if I let's say that
I'm just saying.
I can, if by going from 5.6 to 5.3 or 5.2, I kind of delay that onset of prediabetes by 5 or 10 years. And yet the trend line is going to be the same thing throughout the next 20 or 30 years of my life. You don't feel like there is a health span change to delaying
I
that
doubt
part
it.
of the that part of the continuum of this chronic disease.
Yeah, I doubt it. I mean, and that's based on a couple things. So, one is the from a quality of life standpoint, you're worried about mostly paresthesias, right? Like if you're 90 or your kidney function is less than it could be slightly, but you're not on dialysis, I don't know how much that really affects you, right?
Yeah.
So it's blindness and paresthesias that are, and those are both pretty high glucose before you start running into those. Like that's not pre-diabetes. That's pretty far into untreated diabetes for a long number of years. And then if you're talking about the cardiac effects, there was a recent paper actually sort of debunking the idea that diabetes is a cardiac equivalent or a MI equivalent, right? And I think again what we're seeing is part of that is hinging on the new generation of meds. So it's a cardiac equivalent if you're controlling the diabetes with insulin or with sulfonylureas, which is insulin. But with the new generation of SLG2, and GLP agents,
Yeah.
I think the game has changed, and so I don't know that we're going to see the same. If like here's that's a great example is like why not go on? We're not there yet, but why not go on Wegovy for 2 months, right? Like you'll undereat pretty dramatically, right, for those 2 months. Probably resensitized to insulin because you'll be undereating dramatically, and then come off of it, right? And I don't know. I just wonder. Yeah, I really do wonder. Number one about the idea that there's an inevitable rise. I think that that is true on a population level. I don't know that that's individual destiny. But even if that were true, I think the question is still like at what point are you crossing 6.5? And if your rate of rise is so low that you're not crossing 6.5 till you're 80, then okay, maybe by 90 you'll start to have the beginning, assuming you don't treat it, right? Like that's also a weird assumption is that you at 80 you cross 6.5 and you don't treat it for 10 years, then at 90 you would have some effects. I just don't know again that maybe the short way of saying this is I'm not sure how much I think prediabetes is actually a cardiac risk factor. Maybe that's the short version.
Or hyperglycemia as it relates to, cancer promoter or any of these other downstream potential effects.
Yeah, I don't know. I mean, I'm a fan of fasting for those reasons. If you want, the autophagy and all of the theoretical benefits there. But now we're doing theoretical treatments for theoretical harms, which I'm okay with. But I haven't seen real data that says that prediabetes increases your diabetes does. I know that, but does an A1c of 5? Do people with an A1c of 5.5 have a markedly, measurably increased risk of fatal cancer compared to people with an A1c of 5? I don't know.
Yeah.
Have you seen? I mean, maybe I'm not aware, but yeah.
No.
So
I'm just
again,
making assumptions along the continuum of it.
sure, and I get that, but I think that yeah, I guess it's just, I'm increasingly suspicious of these narratives. I guess maybe that's my takeaway. I think doing a CGM is great. I think it can give you great data on what things are affecting your blood sugar. So you may, and I think doing it for 14 days once as you're eating, you may find that, oh, well, that meal in particular. So for instance, I used to eat at this particular Chinese restaurant, and No other Chinese restaurant had this effect, but when I ate there, no matter what I ate, my blood sugar was like 180. I don't know what they were putting in there. I don't, like literally eating cake didn't get it to 180, but that food did. So I stopped eating there.
Mm.
Like but so it can give you that kind of data. I think that maybe some particular thing is throwing your A1C higher than it should be.
Mm.
I don't know. The other one I didn't quite see iron levels, that kind of stuff. In
My
the
ferritin is down versus where it used to be, but I think it's still in the 200s. Give me one
okay,
sec.
so that's also good. I mean, that's an inflammation marker to some degree, right? Um, Again, questionable value. Um, the only reason I bring that up is that
241 versus 9 months ago, 343,
mm,
and a year and 4 months ago, 418.
I mean, we can lower your A1C immediately. Donate blood. Just go donate blood, and your A1C will immediately be lower.
Don't be a smart aleck.
Just
Yeah,
get
I
rid of
have
your current just get rid of your current sugary blood and have your body make new fresh unsugared blood.
I have smart alecks that I live with. I don't need.
Um no, it just makes me wonder if there's any reason why your blood cells might have a longer lifespan. Iron deficiency is a common reason, but if there's any other reason why your blood might be hanging around longer, you'll get a falsely elevated reading too. Just something to, I mean, maybe
Okay.
not, just something to think about.
So, I
All
mean,
that
is this?
hydroxyurea you're taking.
Yeah. So, I mean, as it relates to health span, you know, are you saying that similar to the process of strength gains in a person that's never lifted in their life versus somebody that's lifted for 20 years now? Like there's only so much you can do after you've already lifted for 20 years to gain strength. Like you're going to gain a microfraction potentially for a whole lot of output. Where if you
Yep.
haven't worked out at all, you're going to have pretty sizable gains with relatively minimal effort relative to the other guy.
Correct.
So is it the same thing given that I'm not smoking, given that I'm have a relatively normal weight?
Yep.
There's micro changes that I might make,
Yep.
but it's nowhere near what I'm going to see if I quit smoking and go from 350 pounds to 150 pounds.
Yep.
Okay.
I mean, you're exactly right. And the health impact of dropping your A1C from 8 to 6 is dramatically different than the drop from 6 to 5, right?
Yeah.
And so, it's number one, more work from 6 to 5, but it's also less effect. And I suspect that the effects, if real, are so small, we will struggle to even generate science to prove it ever. And so, because you probably need to do 5 or 10 of those small things to produce an impact measurable over a population. Um, and so, yeah, I think that, and that's why I emphasize probably moving into measurements of function, because if you're talking about health span, being able to get up out of a chair when you're 90 is a way bigger deal than your A1C being 6. Like if you can't stand and walk around, that's a
Mm.
tremendous impact on your
Yeah.
health span.
Yeah.
And so if you're putting, now at your current age, if you're putting time and energy, I think you're putting it exactly right, is build muscle, build some cardiac function. I will say, in terms of variance, the other thing I've a little bit been leaning towards on a philosophic basis is hitting your max heart rate once a week. Like one set, one rep, just sprint at the end of some workout till your heart rate maxes once and call it a day. Just that
Yeah.
way, your heart maintains that variability through the week on some level.
Okay.
It's those kinds of things because I don't think we're going to get good scientific guidance because the improvements are going to be so small per intervention. It's going to take several interventions to, if you gain muscle and you do this sprinting and you do the zone 2 and you're eating pretty healthy and maintaining, okay, now maybe the sum total of those, you could do some sort of weird study that would pick up on a difference, but it's going to be hard.
Yeah. Okay.
But
So I can just eat cake, right? And
that
keep my total caloric load down and
correct. That was the message. Yes, that's
take Wegovy and fast for 3 days every 3 months.
I mean, actually, yeah. If you throw the fasting in, you might be able to get away with that. That's actually also possible.
Yeah.
I am curious. I have to say, nobody seems to be doing the protocols I would find interesting. So I would find it interesting if you did one dose of testosterone a month, then 3 weeks off, and 2 weeks on, 2 weeks off of low dose Wegovy, like the baby, like the starting dose, not the full dose, like point 0.5 or point 0.2, whatever. And you just had 2 weeks of caloric restriction that was psychologically easy because you felt full, and 1 week of testosterone boost without actually suppressing your own axis, right? Long term, you'd suppress it for the next week, but then you'd have 2 weeks at normal. And if you kept lifting and working out throughout that, I wonder if you would accelerate muscle growth, fat loss through those kinds of cycles without, it wouldn't be fast, but over the course of a year or 2 years of that kind of thing.
Well, do you think if you have me with, let's call it a testosterone of 600
Yeah.
versus my clone who had testosterone of 100 but then supplements up to the 600 level, does either of us have an advantage in gaining and keeping muscle mass?
It depends a little on why his was 100. Like it can't be that much of a clone, right? So there is, because there's some reason why his was 100 and
Yeah.
yours wasn't.
Yeah.
Um,
Let's
but
say he's overweight and has sleep apnea.
well, the testosterone will make the sleep apnea worse. But um, I would say yes. He probably has some. Okay, so actually, I take that back. What I am saying is not based on actual measurements. It's based on my understanding of the system to the degree that I understand it, which is not great. But whatever your norm is, if you are not low for you, right? Whatever your correct natural set point is, if you
Right.
supplement above that, you will get muscle gain benefits, right? If he was, presuming he was at his correct natural set point at 100, supplementing to 600, he will get all the benefits of testosterone, right?
Yeah.
He certainly would have more benefit, regardless of what his natural set point was. He would have more benefits compared to where he was. So if he's overweight and whatever, he will certainly lose weight and gain muscle compared to where he was at 100. That's
But if we're
that's true
both
of
at
everyone.
600 and we both go into the gym and do the same amount of work, does one of us gain more muscle?
He would, yeah. Oh,
Because
that also depends on how I think that depends on whether 100 was his natural set point and he's over supplementing now, or whether he was hypogonadal for some reason and he's just bringing himself back up to normal.
yeah, okay,
So yeah, but I don't. He would gain more muscle than he would have at 100, obviously. Whether he would
sure,
gain more muscle than you depends on whether he was hypogonadal at 100 or whether that was his normal place.
okay,
And because that's a tissue sensitivity to testosterone question.
yeah, okay.
So
All right. So you just want me to go do wind sprints? That's what I'm getting out of all this.
correct. Correct. And lift heavy.